Vamos. So, may we restart? Yep. Beep, beep, beep. We're going to the second phase of this morning. And we're going to start with very brilliant presenters, I must say, without any modesty. So the first one is going to be Cristiane Duarte. Cristiane Duarte is, her background is in psychology. She did her PhD over here in Brazil. And she's a very good picture of brain drainage. She became a professor in Columbia, assistant professor at the Division of Child and Adolescent Psychiatry at Columbia University. And I must say to Mirna that we are always looking forward if we can bring her back. So be careful with us. So Cristiane, it's yours.
Thank you, Rodrigo. It's a pleasure to be here. After 13 years, I must say that it still feels like home. And I just feel that I'm a really fortunate person to be able to call home a place like Unifesp and a place like Columbia University, two outstanding places of production of knowledge in psychiatry and so many other things. It's great to be here among so many mentors, friends, colleagues, and students. I'm going to shift gears, I think, a little bit from what we have been talking about. I'm going to broaden the lens a bit. And what I'm going to try to do today is to convince you that we should go back to thinking that there are really huge advantages to going back and thinking about context when we are talking about development of child psychopathology. Next slide, please. And basically, I'm going to try to make the case that there are advantages of thinking about context when we think about etiology and treatment and prevention of mental disorders. And that by doing that, we place ourselves, our discipline, at a better place, at a very good place, let me say, to converse, to exchange, to have a dialogue with other disciplines and policymakers, and that is something that I think placing our discipline in the public mental health conversation and global mental health conversation is good for all of us. Next, please. So what is context? Context is so many things, and that's one of the big problems that we have, okay? Depending on the discipline or what point in time we're talking about, people are going to call it different ways. But the main idea is that I want to convey is that context is a very important component of understanding the types of behaviors and problems that we are interested in. Next, please. And I'm going to start with the very basic descriptive epidemiology. This is data from the WHO World Mental Health Survey. And what you can see here is the variation in percentage of adult psychiatric disorders in the past year that was ascertained when we used similar methodologies and the same diagnostic instrument around the world. I think in this field, and I'm guilty of that as well, what happened was that cross-cultural psychiatry and psychology had for the last decade, before the last decade, insisted in trying to homogenize the notion that disorders, they are the same all around the world. And this notion had to prevail until a certain point because we were very concerned about making sure that people understood that our diagnostic categories were valid. But now, in the last 5 years or so, some studies have shown, using more strict diagnostic assessments, that there is, yes, a lot of variation across different contexts. And next, please. This is a tabulation that we did in our group of child and adolescent mental disorders. And here we see also a similar situation that for me is even easier to understand. These are all studies that were done using diagnostic instruments. They're not the same as we showed in the adult. There is no such a large-scale study of, international large-scale study of children. But what you see here is defining disorders in a more strict way with a diagnostic interview. You have lower rates in more developed countries compared to developing countries. The Mexico data is based on adolescent only, so there is some inflation here because that's when you start having some of the disorders. But the point that there is variation, I think, is clear when we look at child and adolescent disorders as well. Next, please. And then I want to illustrate why thinking about context can be really relevant with the last issues related to gene and environment interactions in psychiatry. I'm not going to get into the dispute of if the interaction really exists, and I don't want to go there exactly. I just want to show here that more about 10 years ago, that's when we started describing the first interactions with the serotonin transporter here and the MAOA later on. Next, please. And this is a meta-analysis. This is from 2009. There is another meta-analysis summarizing a more recent one that actually got different results. I'm going to discuss that a little bit. But looking at the serotonin transporter, this one had negative results, so the interaction was not actually significant, and there is a lot of controversy. The field is very confused as to if the interaction with the serotonin transporter exists or not. Indeed, as I said, the second meta-analysis, I think is 2011, did use these studies and some others and did find a significant interaction, but I don't want to go there now. What I want to show you, next slide please, is that if we look at the impact of the environment of the stressful life events, it is always significant as compared to the main effect of genes. So that is not really controversial, that there is an impact of the environment. Next slide, please. And here you can see this. These are just the odds ratios of the individual studies that I just showed you in the meta-analysis. So if we look here at those who had 3 or more events, for all the studies that had like a substantial sample size, more than 400 people, they're all significant odds ratios and at a reasonable magnitude of 3 or more, suggesting, again, that the impact of the environment is always present and really relevant. The problem here, and that's the point that I would like us to think about, next slide please, is that, for example, if we think about the way that Caspi defined this contextual or life events in its first paper, it's a combination of 14 events, including employment, finances, housing, health, and relationships. So everything basically under the sun. And the problem with this is that it's absolutely useful for us to understand general etiological processes. However, it doesn't help us much about how should we intervene, or what is the aspect that we can target that can have an impact. What are the modifiable factors that we can target that can actually make a difference? Next slide, please. So what I'm going to do very briefly here is just try to illustrate with 3 studies that we are doing in our group at the Division of Child and Adolescent Psychiatry at Columbia, very briefly, how we can focus on context in a way that can be linked to major public health relevant issues, and that can be quite informative to policy and to how we can inform and change the way things are done. So I'm going to start, next slide please, with the study that we did after 9/11. This is a follow-up of, we have 2 samples actually, one in which we have kids whose parents were exposed to 9/11, so they were either in one of the buildings or were first responders that ran into the buildings. And we are following these kids over time, and now we just got access and were funded to also follow a sample of kids who were themselves directly exposed, meaning they were in schools or residences in the area of the World Trade Center, and we are also following these kids. And this is our longitudinal studies. We have about 800 kids here, about 1,500. This study, we have collected almost all the data for 2 waves. Now we are trying to fund the 3rd wave. And what we are seeing in the kids, they are fairly young, young meaning 9 to 15, and they are growing up as we speak. So basically what we found at that point was an increase in anxiety-related disorders. So this is where we are now. These kids are, as I said, are growing up, and they are becoming adolescents and young adults, and we want to understand how something like a major disaster that happened and that impacts a whole population may have an impact even through parental exposure, which is not a way that we usually think about exposure, especially with kids, but which is very important for kids, may influence their responses. Next slide, please. This is another study that we are conducting. And this is a study interested in the familial transmission of psychiatric disorders and substance use in the context of parental criminal justice system involvement. So here is what you see is the rate of US imprisonment in the last years. And what you can see here is that since the drug laws that were in place around this time generated an increase in the rates of harassment in the United States that is unprecedented in American history and in the world. So the United States these days is the country that arrests the most people in the world by far. And these arrests are many, many times for very minor crimes. For example, we have a significant proportion of people in our sample who had been arrested because they jumped the subway turnstile, and they were caught because they had their skins had the wrong color, and then they are imprisoned, and that has triggers a series of problems in the lives of some families that were already very unstable to begin with, and as easily as it was to start this policy in the 1980s, it may be also very possible, if we produce the right data, to change the way things are done. So this is an example of a study that focused on a highly modifiable risk factor, contextual factor that we can modify. We are assessing about 800 kids. It's 2 waves of data. It's not a very easy sample, as you may imagine, not a very stable sample to recruit and to maintain, but we are doing our best, and we are in the middle of the follow-up, and I hope to have more specific data when I come back, hopefully soon. Next one. So this is the last study I want to talk a little bit more. This is the Boricua youth study. Boricua is a nickname that we used to call Puerto Ricans, as we say carioca here for people from Rio de Janeiro. And in this study, what we have is about 2,500 kids in 2 sites, the South Bronx in New York City, which is, I would say, the equivalent here in São Paulo to Capão Redondo. That is an area where you have a very high concentration of all the risks that you can think about. And San Juan in Puerto Rico, which is the place where people come from. There is a very intense relationship and sometimes tense between the U.S. and Puerto Rico, but very big migration. At this point, we estimate that there are more Puerto Ricans living in the U.S. than living in the island, actually. And what we are doing here, we have just been funded to do a 4th follow-up of this sample that we followed up before for 3 waves, 3 yearly waves we had more than 85% of compliance in the end of the 3rd wave. And now these kids who were 5 to 13 are now 16 to 23. And now we are looking at outcomes such as drug abuse and high-risk sexual behaviors. What I want to show you here is the way that we have been looking and considering the role of context and some risk factors that we can think about that we may not have considered before. Next one, please. So this is our model. I know it's not very simple, but maybe a little simpler than the genetic network, the network of genes that showed us before, just to say that it's possible. And basically the way we were thinking about this, we actually adapted a model that is used for interventions on high-risk behaviors among youth, and we adapted this model to include a series of elements of what we call the social, structural, and social cultural contexts that are part of the lives of these kids, and also to include some systems that are relevant for emerging adults, so adolescents who are becoming adults, which have to do with their work life and the types of links that they are establishing as they grow up and make new relationships. And we want to understand how all these factors, they in combination or through a triggering effect, may end up into these behaviors. So just to illustrate how this can be thought about in terms of the influence of context, let's think about how successful we could have been with our individual or pharmacological interventions to reduce smoking, for example, if we hadn't figured out that peer pressure and cultural contexts were so important, and we had changed the actual culture of smoking in the world. So how effective all our effort in developing the right pharmacological interventions would have been if we hadn't come up with a contextually based policy of preventing people from smoking. So that's just a question that maybe we should start thinking in the area of mental health more seriously as well. Next, please. And these are just some examples of our work on where we showed, for example, that cultural stress was related to an increase in antisocial behavior over 3 years. These are regression coefficients. Don't worry about the side differences because they are not really statistically significant, but both cultural stress from youth and from their parents. So this is a factor, a cultural, contextual factor that we do not usually think about that could be important, and it was very important for this population of kids living in the South Bronx. Next. And the same thing is for this interesting protective factor. Here what we looked at was parental familism, which is a notion, a value related to how important families are, how important it is to be in a cohesive family. And this value, as you know, you may know, is not necessarily carried on in American culture that has slightly different values. So what we see here is a protective effect of parental familism of a value in, again, the development of antisocial behaviors. And here, very interesting, and we have found this for in other studies with different outcomes, it's particularly important for girls, it looks like, that some of these contextual factors that we have been looking at have a particularly strong effect on girls. And there are many speculations that we can make of why that is. It's an open area, I think, and very important of investigation. Next one, please. And just to finalize, this study is a paper on bullying. And what we found here was, as you see, very strong site differences in the rates of bullying in the Bronx compared to Puerto Rico. And then we tried to explain these differences using different factors at the individual level. These are odds ratios. Okay, so the odds ratios, when we add consider individual factors, is still significant. We add familial factors, still environmental factors such as school climate, neighborhood characteristics still, but when we put the cultural factors in the model, that's when the site differences between Bronx and Puerto Rico are explained. Again, suggesting that if we think about context in a more targeted way, we may be able to identify specific points to intervene. Next one, please. So now I just would like to shift and really think about how and why thinking about these issues, context and psychopathology, how that can move us ahead in terms of understanding prevention and being more effective in terms of prevention and treatment of child and adolescent mental disorders. And next one, please. So I'd like just to start with an example, just to make the point that we can treat mental disorders. This is a meta-analysis of use of IPT for treatment of depression. And what you can see is there is plenty of evidence to say that this can be done. effectively. Next slide, please. Particularly including, these are two studies in children, and they were done in low-resource settings, one in Uganda, the other one in Puerto Rico. So also illustrating that it's not that this is a luxury items that can only be used in places where there are lots of resources. No, if we use some strategies like task shifting and others, we can do that in low resource settings. So this is very good news. This is also something that I couldn't be saying here 5 or 7 years ago. And so we need to be carry out this message because it's an important one so that people can hear to what we have to say. However, the problem is, the next slide, please. This is just another example that in humanitarian settings, psychosocial interventions can also be quite effective. But the problem is that how do we actually make these interventions that can potentially be effective, that we need to refine, but are very promising, how do we make them get to the kids who need them? And this is, in my opinion, the biggest challenge that we have, which is what is known, next slide, as the mental health gap, mental health treatment gap. So in my mind, this is what we should be devoting our efforts to, understanding how we can reduce this gap. And I'm going to illustrate exactly and quantify it for you. But I just wanted first to get this message across. Next slide, please. So the message is, let's increase children's access to effective care. So if effective care is possible, how do we get children to the care that they need? Next slide, please. So we have been developing a research program here in Brazil for the last 10 years in which we have been trying to address different components of the context of care and of needs of children so that we can fulfill this goal. As you've can see here, this work has been supported by many different entities, the Ministry of Health in Brazil, Pan-American Health Organization, the Norwegian government, and now more recently NIH, and I'm going to talk to you a little bit about this. So the first thing that was very important to do, next slide please, was to actually quantify the gap. And this is an illustration of the gap. What you have here is the percentage of service use by children and adolescents with mental disorders. So all these kids, they need help, okay, because they have a mental disorder. The disorder in these studies, there's a tabulation that we put together as well, were defined by a diagnostic interview. Here in Brazil, we defined using the CBCL, okay? So the first point that I want to make is that in Itaboraí, where we have been working, about 13% of the kids had used any service, mental health related service in the past year. So this is the gap, okay? It's enormous. As you see, it's big in other developing countries as well. And I just want to make the point also that even in the United States and in Finland, it also exists. We are not seeing, in the United States, we are seeing 50% of the kids, a little more than 50%. So it is, in my opinion, a big problem that we need to find out how to get closer to kids and provide mental health services. Next slide, please. This is an illustration, not specifically of the mental health gap, because here we are looking at service utilization as a percentage of the total population, but an illustration of inequalities that may exist in the use of services. So what you have here is, in the sample that I just described, the Boricua use study, service utilization in the Bronx and in Puerto Rico, use of psychotropic medication and stimulant use, and you see that it's always higher in the place where you have a context that has more services. And so, but these inequalities, and this is something that I think we should all be concerned about. Next slide, please. It's very likely that these inequalities may become larger. Because what happens is that we have been producing with our interventions more knowledge and technology to avoid mental health problems. And when that happens, what happens actually is that sociological and contextual factors, as the ones that we are concerned about, they tend to be more important in the determination of disorders. And I think this is very well illustrated in the next slide, where what you have here is the rates of heart disease in the United States. And what you have here are blacks and whites. And what you see is before all the advances in medicine related to treatment and prevention of heart disease appeared, you had rates between both groups that were more or less the same. And as those advances, they take place, what happens is it goes down for everybody, right? So you decrease the gap, but the disparities, they start becoming larger and larger. So this is something that I think if we are not actively concerned about and trying actively to avoid, I think it's something that can happen in mental health as the technologies or the interventions that we have that work are going to be distributed in a context that is already of a lot of inequalities and a huge gap. So I hope we will be thinking and finding strategies to decrease these inequalities from disparities from the beginning. The next slide, please. So the idea is that to bridge the gap, one very promising approach is if we can focus on the context of care. And next slide, please. When we talk about context of care for children, we may need to think about it in a much different way than the way that we usually think about context of care for adults, because kids are usually, one of the reasons why we see only 12% of the kids in the mental health sector here is that some of them are really being seen, I don't know how effectively, but in many, many other sectors of care. So this is a complication, but if we don't consider the complexity of the context and we don't try to address it in its complexity, but still having some very specific targets, we're going to miss the point. Next slide, please. Trying to address this issue, we did a survey of about 520 child serving agencies in 4 sites in Rio, one area of Rio City in Niterói, Itaboraí, and Volta Redonda. And we looked at the presence of a mental health professional, that would mean a presence of some type of mental health capacity in 4 different sectors of care: health, education, and child welfare. And again, what we found here was a very, very big differences depending on where we were. And in one specific area here in Itaboraí, we identified, first we had the situation of a very favorable situation for the type of work that we were doing, which is very important if we really want to change things and make a difference. But we also saw this very low rate of mental health in the health sector, which is not exactly what we expect. And in that place, we had a very good program, family health program in that area. I don't know if everybody's familiar with the family health program, or as I learned recently, family health strategy. Which is a geographically based primary care strategy to reach out to the population. So we are very curious about what was happening here and how that situation could potentially be changed. Next slide, please. And then, we thought, okay, so if we really want to see what's happening, let's try to change it. And the idea, next slide, please. What we designed was with Dr. Milton Weinberg, who is here, was an intervention for the prevention of high-risk sexual risk behaviors among adolescents with mental health problems. And this strategy has shown it's very promising in the sense that by putting together mental health and a health problem in the health sector, we had been able to have get much closer and get much more interest from the people who were trying to work with kids with mental health problems than we would have otherwise if we're exclusively focused on mental health. So it turns out to be a particularly interesting strategy to reach out to those kids that we're so interested in reaching out to. Next slide, please. This is the design of the study. It's funded. We have started. We are doing the formative phase. We're working there in Itaboraí last week. We are going to adapt an intervention that is called Brazil Style, that is based on an American intervention that was done with 618 adolescents, was an effective intervention. So we are not departing from zero. And we are doing all the adaptation process, and we are going to do a preliminary pilot test of this intervention with about 150 kids. But the most interesting and important thing I believe, of what we are doing is that, next slide, please. We are implementing this intervention in three, this is the Itaboraí, the places, the PSF units, in three main systems of care for children. The CAPC, which is the psychosocial clinics, the ambulatory, which is an outpatient clinic, and in the PSFs. So we want to see, these are three types of service provision that exists in Brazil. And if we can work on these three different settings, on these three different contexts, there is a possibility that this can work in other parts of the country. So this is the idea. This is what we are, next slide please. We are trying to do is to, from the beginning, think about how this intervention can show its efficacy in Brazil, but in contexts where we are likely to reach the largest number of children. And I think that's an important message that I would like to leave you with. Next slide, please. And thinking how, we could here think about, and that's an important issue, think about things from a different perspective many times. And there is a lot of world interest in what can be done in Brazil. One of the reasons being, the ideas that were conveyed to the world and that were paradigm shifting in terms of HIV, the HIV/AIDS epidemic with the antiretrovirals, and etc. So in this case, if we think about the primary care strategy that we are using, next slide too, please. So what you see here, this is an editorial in the British BMJ talking about the family health program in Brazil and thinking about how this can be a strategy that higher income countries could learn from because of its cost effectiveness, which is a huge problem around the world. Everybody is struggling with how to provide primary care to the people who would have the most access to in an effective way. So here we can really think about things upside down and how we could inform other things that are happening in the world. And just to finalize and to become a little more creative, next slide please, these are different, this is an economist comment on the Bolsa Escola, a Bolsa Familia program, and how if there are some ideas that we could have, in the mental health community, how to build upon this program that has had such an impact on poverty, and we could think about some strategies how mental health could also be touched by things like this that exist not only in Brazil but also in Mexico. And so I do believe, and next slide just to finalize, that there is a need to generate information about how context is related to child psychopathology. But that information has to be geared towards informing intervention, science, and policy change. So we don't need another study to say that poverty is related to mental disorders. What we need is to identify what is it specifically and factors that we can modify, that we can. And finally, that intervention science that is serious about decreasing the mental health treatment gap through dissemination and implementation needs to be tailored to needs of the local context where the intervention will take place, while also conversant, having a dialogue with the broader context of national and I would say also international policies. And that's what I would like to leave you with. Next slide. Just a lot of people have participated on this, and thank you very much for your attention.
Congratulations, Cristiane. Marvelous talk, and now you understand why we want to steal her back to Brazil. It's open to the public. Questions, comments? Back there. Do you wanna? You've got a beautiful voice.
Yeah.
Fits in because, at least in the language you're using, it's kind of surprisingly absent, but perhaps it's kind of covered in the broader mental health domain.
Yeah, the way we're thinking about this is in a very broad way. So we do include substance abuse. The study that I showed the Puerto Rican kids is focused on specifically substance abuse. The work we're doing in Brazil is not yet focused on substance abuse, but we do have in our team this interest and capacity, and we're thinking about the best ways of expanding this area. But we agree with you, this is a major need, and if you look at service use by those with substance abuse in the United States, national sample, it's 9%. So most people with substance abuse are really not seen in services. So we really, if we want to reach out to them, we really need to think about creative strategies that can penetrate the population in a very broad way.
Yeah. Thank you. And just a quick follow-up. Maybe I'll come and mention this to you one-on-one, but we're initiating some work in Juiz de Fora, which we expect to be elevated to a national level on the treatment gap for adults related to substance abuse.
That's terrific. Okay, I'd like to know more about it.
Any more comments? Questions? Oh, please.
I'm not going to say how brilliant you are because you are somebody who feeds me every day in brilliant thoughts and ideas. Being this week here and when we were talking about services, every time that anybody talks about the strategy, the family, you know, the Unidad de Desarrollo Familiar, Programa de Desarrollo Familiar, and the strategy of family, everybody says that it works in small places but doesn't work in the big cities. So how do we deal with Rio, Sao Paulo, Belo Horizonte, New York, Washington, and other places that are tremendously populated? Any thoughts?
Just an easy one, right? I think then the complexity is a little more overwhelming. But I think we need to think carefully about models of what are the main factors and then try to tackle them, and the main solutions, the main potential. So when you have also a lot of people together, we see that in the Bronx too, one of the things that you have is a lot of connections, and you can build upon those connections. That can be a way, a strategy, but I think that remains to be thought out more properly. Okay.
Okay. So I think do you want to make a last comment?
No, I'm okay.
Okay. Thank you very much, Cristiane.